It should be live soon.
And what was the name of the emergency medicine doctor? Was it Dr. Chamrita that was recently on?
Yeah, Dr. Siri, she was on last week.
Yeah. Okay.
Marty. Dr. Shamarty.
Chamarty. Okay.
We're live now.
Okay.
So, hello, Web Shadowers. Thank you all for attending our session this afternoon. Today we have the pleasure of hosting Dr. Smith, who will be teaching us about emergency medicine. And as always, please remember that the Google form will be posted in the chat box and in the description of this video at the end. And with that being said, Dr. Smith, you may start whenever you're ready.
Hi, so my name is Dr. Kristen Smith. I am an emergency medicine resident, and I am going to kind of give you guys some information about emergency medicine and also osteopathic medicine. If you look at this title side behind my name, I have the initials DO instead of MD. So we'll talk about kind of what's the difference between DO and MD. Talk a little bit about the basics of emergency medicine and then get into a clinical case. For you guys who were on last week with Dr. Chamarty, I did see some of her slides, which was excellent content that kind of went over some cases that had to do with shortness of breath when they come into the emergency department and how to work that up and how to use ultrasound within the emergency department. So I definitely suggest if you didn't get to see her lecture that you take a look. So just a little bit about my background. So I went to undergrad at Case Western Reserve University. And I actually did take some time off between undergraduate and medical school. So I am what, a lot of people are called non-traditional students, meaning you don't go straight from undergrad to medical school, but you take some time off in the interim. So for myself, I did an informal post-baccalaureate program where I was taking some graduate level science courses and also was doing cultural competency and health disparities research. I then went on to attend the medical school at Rowan University School of Osteopathic Medicine, that is in New Jersey. And then currently I am in my last year of emergency medicine residency. And please ask questions along the way. I know there'll be a lot of slides and content here, but we want to make this as interactive as possible. I just wanted to get that out there. So as you probably noticed, like I said, I have DO after my name instead of MD. So there are two types of physicians within the United States, those who go to allopathic medical schools and those who go to osteopathic medical schools. So osteopathic medicine is practice of modern medicine that includes diagnosis and treating diseases and performing medical procedures and surgeries, just like an MD. It incorporates modern medical practices, knowledge of pharmacology, different diseases, and also what is unique about osteopathic medicine is that it incorporates knowledge of the structural components of the musculoskeletal system and the idea that the body is a unit to actually diagnose and treat diseases. So medical school within the US is usually all made up of the same framework, if you will. So whether you go to MD or DO school, it's usually a 4-year education. Now, there are some novel programs that truncate your medical school education into 3 years, but most medical schools are still 4-year programs. So the traditional model is that you get 2 years of didactic classroom-based coursework. So during that time, you're getting the basics of medicine. You're learning about different diseases, medications, biochemistry, and then your last 2 years are focused on getting your clinical education. So that's when you actually go out into the outpatient clinic setting or out into the hospital to actually see patients. In addition to this general medicine education that you get as a medical student, osteopathic medical students also complete coursework in osteopathic manipulative medicine. And again, osteopathic manipulative medicine, also known as OMM, is that hands-on medicine that is used to diagnose and treat diseases using the musculoskeletal system as a framework. So both MDs and DOs are able to complete residency, and after residency, if you want to get additional training, it's generally called fellowship. So as a DO or an MD, you're able to complete residency and fellowship in any of the medical specialties out there. So as a DO, I could have become a surgeon, an OBGYN, a cardiologist, whatever I chose. I chose emergency medicine because I think it's one of the best fields out there. But I have really enjoyed my training. And like I said, I'm excited to speak with you all today. For anyone who's interested in osteopathic medical school and learning more about what the requirements are to apply, I definitely suggest that you visit AACOM. So this website will give you more information about what the requirements are and how you can apply. And it just gives you knowledge, because everyone on this call is either pre-med or post-baccalaureate student, so you know how to apply and how to increase your chances of getting into medical school. And ACOM is the American Association of Colleges of Osteopathic Medicine. And just so you all know, DO students are really increasing. Currently, there are 25% of all students in medical school are at osteopathic medical schools, and there currently are 37 osteopathic medical schools within the country of the continental US, and they're spread across 33 states. So there are some states that have more than one school within the state. So we'll talk a little bit more about my specialty that I'm training in, called emergency medicine. So the basis of emergency medicine is diagnosing and treating diseases in the undifferentiated and unscheduled patient. So what does that mean? Undifferentiated meaning a patient comes in saying, hey doctor, I'm short of breath, meaning they're having trouble breathing. It could be a host of different diseases causing their trouble breathing. Are they having an asthma attack? Are they having a heart attack? Are they having a blood clot to their lungs? These are all things that the emergency medicine physician learns how to diagnose and treat. And then in terms of being unscheduled, this just means that in general, all emergency departments are open 24/7. So any day, anytime. We're really known as resuscitationists within medicine, who stabilize patients with acute diseases and acute presentation of exacerbation of chronic diseases and traumatic injuries. To become an emergency medicine physician, you need to complete your doctorate of osteopathic medicine or your medical degree. So you need to have a DO or an MD. You then need to complete 3 or 4 years of emergency medicine residency. So throughout the country, there are various emergency medicine residency programs, and they're either 3 or 4 years. The time length differs based on how much research and teaching is incorporated within the curriculum. You then can go on, once you've completed your emergency medicine residency training, you're then called what is a board eligible physician. So that means you're eligible to take your board exams to become board certified. And then you can go on to practice either in the academic or the community setting. So like I said earlier, emergency medicine is shift work. So generally you work anywhere from 8-hour shifts to 12-hour shifts, and you can work any day or any time. That includes holidays, weekends, and nights. And then just to reiterate, like I said, you are treating the undifferentiated patient oftentimes that comes in with a complaint, and you are trying to figure out why they are having their symptoms. And you also treat trauma patients. So patients that unfortunately may have been stabbed or had a fall from a building. You diagnose and treat those patients as well. So there's some general steps to evaluating patients within the emergency department. This really will kind of give you some information on how to go about evaluating any patient within any setting, but we'll specifically be speaking today about the emergency department because that's what I'm training in and that's what I'm here to teach you all today. So now we have what's called electronic medical records. They're called EMRs. I'm sure a lot of you all have heard of them. And what you do is that you check the chart of the patient. So a patient will come onto the board, they'll come into the ER, they will go through the waiting room and they will be triaged. So triage means a patient will explain their complaint to the nurse, and then the nurse will get a set of vital signs and take a short history and then determine, is this a patient that needs to be rushed back to the emergency department to be seen right now? Or is this a patient who can wait for a few minutes until the next bed is available? So once the patient is on your tracking board, you can then check their chart. So that's just clicking on their name and seeing a little bit about their medical history. Now, there will be some patients who have never been to your emergency department, so there's truly no chart to check. Then you will review their chief complaint. So we're going to use that term chief complaint within this talk quite often today. So chief complaint is the main reason for the patient presenting to the emergency department that day. So a chief complaint may be right knee pain or chest pain. Those are usually what is called a chief complaint. You'll then go in to see the patient and you will take note of their vital signs again to make sure nothing has changed from when they were seen a few minutes earlier out in triage, or there hasn't been an acute change, or to make sure that there wasn't an error with putting the vital signs within the chart. And then you'll take a medical history. So we'll discuss a little bit about how to take a medical history. We'll also talk about performing a physical exam, developing a differential diagnosis, creating a plan, and determining a disposition. So something that's unique to emergency medicine is really creating a disposition for your patient. So once you've figured out what is going on with your patient and you've treated them, you need to decide whether or not this patient is someone who can safely be sent home, and then recommend that they follow up with their primary care physician or with their outpatient gastroenterologist, or is this someone who needs to come in to the hospital and stay overnight so that they can be observed or have repeated treatments, or receive surgery or any acute intervention that they may need. So before we get into the case, I am going to go ahead and answer a question that came in through the chat. So someone did ask about matching into competitive specialties with a DO. So you guys probably heard that there is now a combined residency match. It used to be two different matches. One for physicians who wanted to train at historically osteopathic medical residencies, and then one for physicians who wanted to train at historically allopathic medical residencies. So now it's all one combined match. So you have a bunch of specialties within the match. I know that there's rumors out there that DOs aren't able to match at the most competitive specialties, but that is not true. If you look at most programs, they have at least one DO training within their residency program. A lot of the competitiveness of a specialty comes from how many positions are available each year and what the average board scores are needed to match into that specialty, and also other qualifications like how many recommendation letters you need, how much research you've done, how much educational teaching have you done. All of that makes you a more competitive applicant for residency, and you can become very competitive as a DO by doing some of these adjuncts, which is needed for any competitive medical student to get into a residency. I did have another question come in through the chat, but we'll save that for a little bit later because I think it's great and it has more to do with our case. So we'll get back to that. Hopefully I answered that question for you. So we're going to get into our case. So you're going to see a patient with the chief complaint of chest pain. So this is generally how we collect a history of present illness for a patient. So history of present illness is basically getting more information about why the patient is coming into the emergency department. There are numerous acronyms out there, and I know as pre-medical students, you guys are used to using a lot of acronyms to study for biochemistry and organic chemistry and all of that stuff. So this is just something that once you get into medical school, you'll learn a lot more. So COIDRS is the acronym that I like to use. So it is best when used for a pain complaint. So for a patient with chest pain, you can ask the patient questions about the character. So is the pain sharp or dull? The location, is it in the middle of the chest or is it towards the left side of the chest? The onset intensity, so was it the worst pain they've ever felt, or has it kind of been a dull ache throughout the day? Duration, has this pain been going on for 2 weeks or just 2 minutes? Any exacerbating symptoms, so these are symptoms that make the pain worse. So getting up and walking around, is it worse when the patient leans forward? These are all things that can help us build our differential diagnosis later on. So it's important to know what the symptoms of different diseases are so that you're asking the right questions. Remitting symptoms. So these are symptoms, well, these are aspects of when the pain is better. So if a patient may come in and say they have chest pain when they're up, walking up the stairs, but when they sit down, their chest pain goes away. And any associated symptoms. Is the patient sweating when they're having this pain? Are they vomiting? Do they feel nauseous? Are they having blurred vision? This is all important in obtaining a detailed HPI for your patient. Another aspect of the history of present illness is the social history and getting more ancillary history. So we use SMASH-FM. Social history, so we'll go into social history in the next slide, but there's another acronym you can use to collect that information. You want to also ask questions about the patient's medical history, so whether or not they have diabetes, high blood pressure. For every chief complaint and diseases the patient may be coming in with, there's going to be specific risk factors and things that you should ask for when you're asking for medical history. And this is just part of getting a detailed history on the patient, is to know what other medical problems they have. Allergies. So does the patient have any allergies to medicine? That becomes very important because if you want to give a patient Tylenol for their pain and for some reason they have an allergy to acetaminophen, that's not something you should give. Surgical history. Has the patient ever had any surgeries? Hospitalizations. Has the patient recently had to stay overnight for a medical problem, or have they ever stayed in the hospital for a similar complaint that they're coming in with today? Family history. Maybe this patient has a very long history of cardiac disease within their family. Maybe their mother or father unfortunately passed from a heart attack before age 50. These are all very critical components of the history to get because that helps you risk stratify a patient in terms of their cardiac risk. Also, what medications is the patient on? Are they already on an aspirin? Do they take any antiplatelets? This is all information that you want to acquire. So when we get our social history, another acronym that we can use is FED tacos. Again, all these acronyms can be quickly Googled, and there's something that once you get into medical school, you'll learn more about, and it will become second nature. I'm just including it here so you all get a sense of how we take a medical history within the emergency department setting. And a lot of times within emergency medicine, patients are coming in critically ill. So sometimes you don't have time to ask all of these questions, even though they may be pertinent to the patient's treatment. You want to make sure that you're hitting the highlights. What are the things that you need to know most in order to properly diagnose and treat your patient? So fed tacos is getting the social history. So you may ask questions about the patient's diet, their exercise regimen, whether or not they use any illicit substances, whether or not they smoke. This can also include chewing tobacco. And something that's important to note is usually you have to ask about marijuana use separately because a lot of people don't think it's a drug. And there are also a lot of people who are on medical marijuana. So sometimes patients don't understand that we still consider within medicine marijuana to be a drug. Alcohol use, caffeine use, whether or not the patient is employed and what type of occupation they do, that can give us really critical information, especially now with the coronavirus pandemic. We are often concerned if a patient comes in saying they're having difficulty breathing and they work within healthcare, that increases their risk for having coronavirus. So we have a little bit higher level of concern for that patient. And also any sexual health risk factors. So for our patient, we have a 60-year-old male who is coming in with a history of high blood pressure and diabetes, and he's coming to the ER complaining of substernal chest pain for 3 hours. So that's pain right here in the center, you guys can't see, but in the center of the chest, right under the sternum. The pain is described as constant. It radiates into his right arm, and it's sharp. The pain is worse when he gets up and walks around, and it's better when he sits down and rests. He's unsure if the pain began gradually or suddenly, but it's been persistent. He took an antacid, and he didn't have any relief because he said that sometimes he has a history of acid reflux, so he wasn't sure if this was his reflux. He's had no similar symptoms in the past. He does not complain of any difficulty breathing. He doesn't have any palpitations. So that means feeling like your heart may be skipping a beat or having an irregular rhythm. He's not feeling lightheaded. He has no swelling of his lower legs. And he hasn't traveled outside of the US or had any periods of being unable to get up and walk around within the last several months. He does not have having any infectious symptoms, so he has no fevers, no chills, no cough, no recent sick contacts, and he's had no trauma to the chest, so he hasn't fallen or been hit in the chest. More information about his past medical history reveals that he has no known drug allergies. His medications, he is on metformin and a multivitamin. His past medical history, he has diabetes, high blood pressure, and high cholesterol. He has a family history of diabetes and coronary artery disease. He smokes 1 pack of cigarettes a day. He drinks 1 alcoholic beverage per week, and he denies using any illicit substances, and he's never had any surgeries. So one of the first things that you would do, or one of the nurses that you may be working with would do, or text, would be to place the patient on the monitor. So this is important for patients coming in with chest pain because it gives us a quick look at their electrocardiogram. And we'll go over what that means in more detail in a minute. But it gives us a second-by-second it can give us a second-by-second output of the patient's vital signs. And you can see quickly what the patient's heart rate is, what their blood pressure is, what their oxygen saturation is, how fast they're breathing, and their temperature. So this is an example of what a, let's see, my mouse isn't working here. So this is an example of what a cardiac monitor may output may show you. So you see here the heart rate, you see here the blood pressure, you see here the patient's oxygen saturation, you see here their respiratory rate, and then their temperature. So for our patient, these are his vitals. So he has a temperature of 36.9 degrees Celsius. He has a heart rate of 102 beats per minute. He has an oxygen saturation of 99% on room air, and he's breathing 18 breaths per minute. Is there anyone who would like to tell me if any of these values are abnormal? So I think someone put in the chat, yes. So the patient's heart rate is abnormal. We can see here that these are the ranges of our vital signs. So temperature, normal is usually 36.1 to 37.2 degrees Celsius. Pulse is generally between, normal is between 60 and 100 beats per minute. So less than 60. Higher than 100 beats per minute is tachycardia, so that is fast heart rate. The patient's pulse oximetry is 99% on room air, which is within normal limits. Usually we're looking for a pulse ox to be 95% or better for a patient who doesn't have any history of lung disease, depending on some other risk factors, their age, their pulse of 92% or better. And then sometimes even lower for a patient who's known to have asthma or COPD. And then a normal respiratory rate is usually from 12 breaths per minute to 20. So now we're going to perform a physical exam on our patient. So the physical exam is a head-to-toe exam, and you want to keep it specific for the patient's chief complaint. If a patient comes in with knee pain, you want to make sure that you're doing a very thorough examination of the knee. That includes looking at the skin, testing range of motion, testing for any type of ligamental laxity, and checking pulses. So depending on what your patient's chief complaint is, that will really dictate some of the things you're looking at in terms of your physical exam. For our patient, I'll just go over some of the highlights of his physical exam and not read off everything on this slide. So as far as the patient's general exam, he does appear a bit uncomfortable. You notice that his skin is warm, but he's also diaphoretic, meaning he has beads of sweat around his brow. His cardiac exam reveals that he has a slightly fast heart rate. He has a regular rhythm. There aren't any murmurs. He has no jugular venous distension. He has no peripheral edema. And he has 2+ pulses in his wrist, over his radial artery, that you can feel bilaterally that are equal. You also check his lungs, and you notice that he has symmetric chest wall expansion. He has breath sounds in both of his lungs that are clear. You don't hear any wheezing, any rales or rhonchi. And those are sounds that can come if a patient has asthma or is having an infectious process, has fluid in the lungs. It just gives us information about different issues that may be going on with the patient's lung. You also notice that the patient has some truncal obesity, so that's really over the abdomen, and the patient is mentating appropriately. So based on what we've learned so far about the patient's medical history and acquiring a detailed history of present illness, what do you think the patient's diagnosis is? What do you think is going on with this patient at this time? I'll give you all a few minutes to kind of think about some things and post them in the chat. I actually think I lost my chat function here. So we'll just kind of go over the differential diagnosis. I'm sorry for anyone who wrote in any answers, and hopefully you'll see your answer pop up on this next slide. So some things to think about for this patient coming in with chest pain is that patient having a myocardial infarction? So are they having a heart attack? Other things to consider are, is this patient having a coronary artery vasospasm? So that is when the arteries to your heart actually spasm and get smaller, and that can cause decreased blood flow. Is the patient having a coronary artery dissection? So that is when one of the arteries going to the heart actually has a tear within it and may even rupture. Is there pericarditis or myocarditis? So pericarditis is inflammation of the sac within which the heart lies, or myocarditis, so that is inflammation of the actual heart tissue. And both of those diseases are seen in relation to infection. Is the patient having some bruising or myocardial contusion due to some type of trauma that they may have had? Does the patient have a cardiomyopathy, so enlarged heart and difficulty with the heart actually pumping? Is there pneumomediastinum? So does this patient maybe have a ruptured esophagus? This is then having air leak out within the chest wall and the chest cavity and causing this pain. Does the patient have a pneumothorax? So to be very rudimentary, just a dropped lung. Does this patient have a pulmonary embolism? So that is a clot in the lungs. Has this patient had a rib fracture, so a broken rib that is causing pain? Or is this patient having a shingles outbreak? So they have a rash over their chest that is causing pain. So we'll go over what we should order to work this patient up. So first, we would like to make sure that we get an electrocardiogram, so an EKG. We also want to get blood work. That would include a CBC with a differential, a basic metabolic panel with magnesium and phosphorus. So that will give us an information about the patient's kidney function and also the electrolytes within their blood. We want to get a troponin, which is a measure, for lack of much detail, a measure of damage to the heart. We also want to get coagulation factors. This will give us an idea of the patient's ability to make clots within their blood. And also some other things we may want to get is called a B-type natriuretic peptide, so BNP. This can be a measure of stretch, and it can give us some information of whether we think the patient is having a heart failure episode. We also would like to get a chest X-ray. So this will give us information about the lungs and about the size of the heart within the chest. And then other considerations. So you really want to base your workup, which is your laboratory studies and your imaging studies, based on the patient's chief complaint and based on your differential diagnosis. So based on all the things that you think may be going on with your patient, you would want to consider what other studies you may need to get. So based on some of the differentials that we went over earlier, we may want to include a CT scan of the chest to see if this patient has a pulmonary embolism, a scan of the chest, abdomen, pelvis to take a better look at their aorta. So that is the large vessel within the body that carries blood to all of your critical organs. You may want to get a rib series X-ray. This will give us a better view of the ribs. And then you may want to get an echo. So that is a cardiac ultrasound that can give us more and more detailed information about how the heart is pumping. So we see here, this is an image of a cadaver heart. So I just wanted to show you guys this. For those that have done anatomy, probably a lot of this anatomy is already familiar to you. And just so we review, we should talk a little bit about blood flow, just so that you understand how blood is flowing within the heart and the body. So we have blood that returns from our lower extremities and our upper extremities through our vena cava. So you have two vena cava, the superior vena cava and the inferior vena cava, and they both empty into the right atrium. So blood is going to return from your organs deoxygenated, meaning all of the oxygen has been extracted and given to your organs. So now you have deoxygenated blood entering your right atrium. That blood then goes from the right atrium into the right ventricle by crossing over the tricuspid valve here. So the blood is now in the right ventricle and then crosses the pulmonic valve, into the pulmonic artery, into the lungs. So some of you may be thinking, oh, I thought arteries usually always carry oxygenated blood. Within the lungs, that is the one difference in the body. So it is actually the pulmonary artery that carries deoxygenated blood, and the pulmonary veins actually carry oxygenated blood. So from the pulmonary artery, then you have your blood then goes through small capillaries into the lungs, and that is where oxygen and carbon dioxide exchange occurs. So now that the blood has been oxygenated, it then exits the lungs through the pulmonary veins into the left atrium, and from the left atrium over the mitral valve into the left ventricle, and then out into the aorta. And as I said earlier, the aorta is the largest artery within the body that has several different branches at different parts in the body, and then branches into other smaller arteries to supply your organs with oxygenated blood. So we did mention that one of the imaging studies that we wanted to get for our patient was a chest X-ray. So here you can see the chest X-ray for our patient. Is there anyone who would like to take a crack at giving us some information about this chest X-ray? Okay. So yes, so just so we kind of overview for everyone, black on a chest X-ray is air, and then white either is bones, organs, or can be fluid, so such as blood or infiltrate from an infection, or solid tumor as well. So we see here on this chest X-ray, this is a normal chest X-ray for our patient. Things that you want to look for when you are reviewing a chest X-ray, I like to use the ABCDE system. So that whenever you are reviewing imaging for a patient, you want to make sure that you use a systematic approach, because that makes sure that you don't miss anything. So if you use ABCDE, that helps you to remember all of the critical components that you need to be looking at when you're reviewing a chest X-ray. So first is A, so that is your airways. So here we have the trachea. So we know that air enters here through the trachea and then goes into your bronchioles and into the lungs. Okay, so we can see our trachea is midline, which it is supposed to be. We can see here the branch point of the trachea called the carina. And then you can see that we have two lung fields here with markings going out to the periphery. So our airway looks fine. And then B is for breathing. So you're really going to take a good look at the lungs, which we see here. The lungs look fine as well. Then C is for cardiac. So you're going to take a look at your cardiac silhouette. So this is the heart here. And you can see different aspects of the heart here. On a chest X-ray, your heart should, about 2/3 of the heart should be on the left side and 1/3 should be on the right side. So this looks about correct. We can see that the apex of the heart, which is this curvature here, is on the left side. And you know, when you're looking at a chest X-ray, when you're looking at it head on, this is your left side. It often will be marked, excuse me. And this is your right side, okay? So that's important to know to orient yourself whenever you're looking at a chest X-ray. So we see here the cardiac silhouette looks fine as well. Then D, we take a look at our diaphragms here. So the diaphragm is the large muscle within your thorax that is needed for you to actually breathe. So here, it's always normal for the right hemidiaphragm to be more elevated than the left. And the reason for this is because your liver sits right under here. So your liver is actually going to push that diaphragm up. And here you may be asking, what is this black space here? And just remember, on the left side of your body is your stomach. So oftentimes you can start to see the gastric bubble or gas, which is air within the stomach, which is normal. So sometimes that comes through on your chest. Oftentimes that comes through on your chest X-ray, as it should. I forgot to mention as well, when we spoke about B, not only is it breathing, but it's also bones. So on a chest X-ray, you can see bones of your thorax as well. So you can see your ribs. It's a good mark that you should be able to see about 10 posterior ribs in a proper chest X-ray, meaning the patient took a maximum inspiration. And then you have your clavicles here. You can see the head of your humerus here. So starting to see your shoulder joint. You can see some of your scapula in the back. So it's important just to make note of the bones that you're seeing and make sure that you're not seeing any fractures. So any broken bones within what you can see within the chest X-ray. Okay, so we talked about A, B, C, D, we talked about the diaphragms, and then E is everything else. So on this chest X-ray, it's a normal chest X-ray, but we may see a white patch here, and that may give us concern for tuberculosis. So we see an infiltrate here, which would be a hazy white patch, or we could see some whiteness here, which would indicate a pleural effusion, or you may see some other infiltrate somewhere that could indicate infection. So you're trying to take a look for anything else on the chest X-ray that shouldn't be there. Sometimes you'll see a foreign body, whether that be a foreign body within the airway or a foreign body entering the chest in a patient who may have been stabbed. You'll also want to make sure that you are looking at the correct patient and the correct date. So it's always important on all of your chest X-rays. Obviously, this is de-identified, and this was actually obtained from Radiopedia. So this is available for anyone on the website, but usually in the department, you will have a patient's name, their MRN number, which is their medical record number, their date of birth, and the date of service. So that will all be somewhere within the chest X-ray film. So you just always want to make sure you're looking at the right film for the right patient. And this is just a annotated chest X-ray. This is also on Radiopedia. So I really I liked to use this when I was in medical school. I think it gives you a lot of information on how to read plain films and things like that. But this just goes over again most of the things that we already talked about. In the interest of time, this is something that you all can come back to later. So then another critical component for our patient with chest pain is getting an EKG. This actually is the first thing that you would get. I just wanted to go over the chest X-ray first so that we could talk through how to actually read a chest X-ray, but the EKG would be the most critical piece of this patient's case. So an EKG records the electrical activity of the heart and can be used to diagnose some heart conditions, mainly ischemia and also heart arrhythmias, so any type of irregular heartbeat. Actually reading an EKG is something that you will learn in a little bit more detail in medical school, and then in residency, you'll learn it in a lot more detail. But just so that you are somewhat familiar and have heard of it, the EKG, you take a look at the EKG, it has 12 leads, and each lead corresponds to a area of the heart. So different changes on the EKG can give us an indication of maybe the patient is having a blockage in this area of the heart, or also can give us an indication of whether or not the patient has different electrolyte abnormalities like hyperkalemia or hypocalcemia. So there's different ways to look at an EKG, but it's a very important piece of your medical data. So this is our EKG for our patient. And does anyone think it's abnormal at all? So I kind of highlighted it for you. But here in the red boxes, I highlighted what are called ST elevations. There's different types of, so ST elevation, myocardial infarction is a heart attack. And basically, ST elevations are when you see more than a 1 millimeter increase from baseline of the ST segment. So here we can see all these ST segments are elevated. And oftentimes it goes by a pseudonym of, tombstoning. So this looks kind of like a tombstone pattern. So this would be a STEMI. This is a medical emergency, and this is something that a patient should definitely come to the ER for and should definitely seek immediate treatment for. If for whatever reason you were ever at an ER or an outpatient office and you saw something that looks like this is something that you definitely should alert someone to. So, like I said, our patient is having a STEMI, and it's a cardiac emergency. And a STEMI is usually caused by blockage of one of the major arteries of the heart. So this means that you have a plaque, and either the plaque ruptured or the plaque has grown in size, and now you don't have adequate blood flow to the heart. In a STEMI, you have complete occlusion, usually complete occlusion of that vessel. So you have very, very little blood flow getting through. And this lack of blood flow obviously can lead to heart damage and also cell death. So it's very critical and important for the patient to have immediate treatment, because the longer you have that area blocked, the more necrosis you get, and the more the heart is not being supplied with proper blood flow and not getting enough oxygen, you have the cells of the heart, the myocytes, which then start to die, and then they can't work correctly. So you can't get proper contraction of the heart, meaning eventually your heart will stop contracting. And when your heart stops contracting, that means you now have gone into cardiac arrest, right? Because you don't have your heart pumping anymore. So that is when you see on TV, or if you've ever seen it in person, a patient gets CPR. So you are manually compressing the heart to try to pump blood throughout the body because the heart is no longer doing it for itself. So the main treatment for an ST elevation myocardial infarction is percutaneous coronary intervention. So this is a procedure where a small guide wire is placed into the heart and the blockage is physically removed or dissolved. Some patients will have a stent put in place to keep that area open and discourage re-occlusion. And usually this should be done within 90 minutes. So if a patient comes into the ER complaining of chest pain, you get an EKG that shows they're having a STEMI. Within 90 minutes of coming to the ER, they should be in the cath lab and actually having the balloon and the stenting performed, okay? Because like I said, all of this is, all of the timeline is important. This is getting into a lot of nuances, but just to give you guys a general overview, there's different hospitals within the United States that have different capabilities. So there's going to be some hospitals that don't have a interventional cardiologist or don't have the ability to do PCI. So sometimes you're going to be giving patients what are called fibrinolytic medications to actually try to dissolve the clot using medications. And that medication, if that's the route you're having to go, should be given within 30 minutes of the patient coming in. So this is a short clip that's going to give us some information about PCI.
Dr. Smith, the audio is cutting off a little bit.
Oh, it cut off.
Yeah, it's kind of lagging.
Oh, I think I may have to re-enter because I think now you guys can't see me.
Are you able to see the chat box?
The chat has stopped.
If you click more and click chat, it should be there. But also your video is frozen. I'm not sure if you got to read it. Dr. Smith? Okay, perfect.
Hi, sorry about that.
No, you're good.
So I'm just going to reopen the PowerPoint, okay? I apologize, everyone.
Okay. Thank you.
Mhm. All right, we're back. Sorry about that, everyone. So hopefully I can see the chat now. So we'll just resume where we were. Always having some technical difficulties. But yes, so we just reviewed the video for PCI. So hopefully that gave you a little bit more information about what PCI actually is. And like I said, that is the preferred treatment for myocardial infarction, for heart attacks, okay? To go in there and try to remove that clot, open up that blockage, and get reperfusion to the heart. This is just some secondary things that are done. Important, but obviously PCI is kind of the most important aspect. But you, in the ER, we mainly are giving patient aspirin, so giving them an aspirin load before they are taken to the cath lab to have their PCI done, and usually starting them on heparin, so an anticoagulant prior as well, to prevent restenosis, reclotting. Okay, and then we often also give another antiplatelet as well. So these are the kind of three main things we're doing in the ER. For patients with chest pain, sometimes we're also giving them nitroglycerin to reduce demand of the heart, and that can help with chest pain. And then these are some other treatments that are given, but we're not usually starting them in the ER. That's usually something that is done on the floor after the patient has had PCI. So just so you guys have a little bit of information about the epidemiology of chest pain and heart attacks within the US. As you know, it's pretty common. Part of it is just the American diet and lack of exercise and the high rates of hypertension and diabetes within the country. Those are all risks for having a heart attack. So every year there are over almost 500,000 of heart attacks each year. Okay, and of these over 500,000 heart attacks, about 21% are fatal. 57% in men and 43% in women. The average age of first heart attack is younger for men than women. So men being an average age of 65 and women being an average age of 72. However, heart attacks can happen, unfortunately, at any age. I've seen many patients who were younger than myself actually come in and have an ST elevation MI. So this is something you should always keep on your differential. And there are different types of heart attacks. There also is what's called a non-ST elevation MI. So basically, this is where you have a blockage of one of the heart vessels, but usually it's either not as acute or the blockage isn't quite to the degree that is making you have these classic EKG changes and findings of the tombstoning and the elevation that I showed you earlier. So those patients still get treatment, and oftentimes they may go to PCI, but it won't be that day. It's not as time sensitive. So 38% of patients with a heart attack actually have an ST elevation type. So we'll talk a little bit about the gender disparities, but someone entered in the chat a good question of why men are at an increased risk of heart attacks. So part of this reasoning is just the prevalence of risk factors for heart disease has some gender differences. So heart disease risk factors are smoking, also high blood pressure, high cholesterol, diabetes, obesity, and also just the way vessels can be set up. There are different pathophysiological differences generally between men and women that put men and women at different risk for heart disease and for different presentation of their heart attack. We actually see that the symptoms with which in general, patients who are women come in complaining of symptoms and men come in complaining of symptoms are usually different. Women usually come in complaining with atypical symptoms, so it won't be your classic chest pain, crushing, ripping chest pain, going into the arms. It may be that the patient says she feels fatigued or nauseous. These are atypical symptoms. So there have been studies that show that women are often underdiagnosed with heart disease and with MIs because of their atypical symptom presentation. So this slide just kind of goes over some of that information. This was from a presentation I have done previously, but there's two basic concepts when we're looking at the gender disparities. So biologic differences based on gender causing a different pathophysiology of the disease. So the firmness of the plaque actually can be different based on women and men. And also you have a different type of vascular stiffness as well. And then there have also been studies that show even when women do have typical symptoms of heart attack, so they're having chest pain and they're describing it in that way, that even when that occurs, there are differences in how women are treated, both in the pre-hospital setting, so by EMS workers, but also in the hospital setting as well. So many studies have shown that women with acute coronary syndromes, which includes heart attack, are less likely to be treated with the guideline-directed medical therapies that we went over previously. They're less likely to undergo the cardiac catheterization, so the PCI that we spoke about, and they're less likely to get that timely reperfusion, which we discussed PCI ideally should be performed within 90 minutes of presentation and at most 120 minutes. So at most 2 hours, and the difference between that 90-minute time mark and the 120-minute time mark is just based on the capabilities of the hospital center. So if you're at a hospital center that doesn't have a cath lab, you're going to need to transfer that patient. And so there's an additional time allotted for that transfer. Okay. So this is just a quote. I do believe life is fleeting. You should make sure to take steps towards your goals each day, which obviously you guys are doing. You guys are rock star pre-meds, doing virtual shadowing, really not letting the pandemic get you down and keep you away from your goal of becoming a medical student and then becoming a physician. And you're still able to get clinical exposure without actually being in the setting. So I really just want to thank web shadowers for allowing me to speak to you all today. And hopefully you all enjoyed the case and learned from it. And at this time, I'd like to open up for any last minute questions that anyone may have. So that's a good question. Someone said, which pre-existing conditions make people at greater risk for a heart attack? So that's really a lot of things that make people at greater risk for a lot of diseases. So if patients are overweight or obese, if a patient has ever had a heart attack in the past, that makes you more likely to have another heart attack in the future. If you have diseases such as high blood pressure, high cholesterol, diabetes, that those diseases cause changes of the endothelium of your vasculature, so you are more at risk of getting blockages within the heart. Patients who smoke have a higher risk of heart attack. Patients who use cocaine, because cocaine causes vasospasm, so arterial spasm that mimics, it causes occlusion, but it can mimic a structural blockage. So you have narrowing of your arteries that supply blood to the heart. So then you have decreased blood flow that leads to less blood flow, ischemia, cell death. So those are some risk factors. Someone else asked another question about family history and risk of heart attacks. Yes, so that is why it's important when you gather your history of present illness that you get information regarding the patient's family history. Patients who have had parents or siblings who have had heart disease are at higher risk for having heart disease and heart attacks themselves. So that's why that's an important marker. Someone also asked about fellowship options within emergency medicine. So I am actually not going on to do a fellowship, but I do know about some of the fellowships that are available within the specialty. So unlike internal medicine, so I think, so the fellowship concept, I think, is really best understood when you're considering it from an internal medicine standpoint, because I think it gives you that kind of information. So an internal medicine physician often either works at an outpatient clinic or they work within a hospital as a hospitalist. So they learn all aspects of medicine, general medicine. And then they often do fellowship where they are actually almost doing a whole different job than what just being trained in the internal medicine allows you to do. So if you complete residency in internal medicine and then do a cardiology fellowship, you're now a heart specialist, okay? Or you do a gastroenterology fellowship, you're then a gastroenterologist. So you're a specialist of all gastric and hepatic diseases. So the concept of fellowship, I think, is best understood from that model. And I think a lot of people think that when, if you're emergency medicine, you may be doing a completely different job, and that's not necessarily the case. So for fellowship for emergency medicine, you're usually getting similar to the other fellowships, but you're getting more advanced training, okay? But you're still an emergency physician who is, like I said earlier, really trained in resuscitation of critically ill patients. So there's many different fellowships in emergency medicine. New ones are coming out every day, but the major fellowships are toxicology. So that is a fellowship where you learn more information about poisonings and drug overdoses and how to treat all of the diseases and sequelae that come from that. And then also ultrasound fellowship. So that is where you get more training on how to use ultrasound at the bedside within the emergency department to diagnose diseases, which you already get by going through any emergency medicine residency, but you get even more in-depth training. So you are able to do more diagnosis, more procedures, and then you're also able to usually go on and become maybe like an ultrasound curriculum developer or the ultrasound associate director for a residency program. So you just have more credentials to get some of those higher level jobs that may need it. There are also fellowships in administration. So that's where you learn more of the business and admin aspects of medicine and emergency medicine in particular, so that you can go on to be a leader within your department. There's also research fellowships where you get more training on how to conduct clinical research, and you can go on to be a researcher. There is also global health fellowships. So now with the pandemic, those fellowships look a little bit different, but you get training in doing international medicine and working within a resource limited area. There's also a new fellowship that is at a few programs called social emergency medicine. So you get more specified training on the social determinants of health and health equity and figuring out how you can create interventions within the emergency department to better treat your patients. So there's a bunch of other fellowships that I probably forgot to mention, but those are the main ones within emergency medicine. So a few more questions. So who typically does intubations in the ER? PA, ND, NP. So generally, the physician is doing the intubations, is performing the intubations. So usually that will be the MD or the DO, whoever the physician is on for that day. If you're at a residency training program, it depends on year within residency, but usually the residents are doing the intubations. And then if it's a critically, or all patients are critically ill that are getting intubated, but if it's a difficult airway, sometimes the attending physician, so the supervising physician, may have to attempt if the resident is unable to successfully intubate the patient. PAs and NPs who go through, PAs who go through the emergency medicine residency. So there are some programs that offer a 1.5 year residency for physician assistants. They are trained in intubations as well, but usually the frequency with which they get to do a lot of the critical procedures that are necessary to practice emergency medicine are less. So they're not always expected to do those procedures, but it really depends on the location. Because obviously someone working in a rural setting is going to have to do a lot more things than if you're working in the middle of a city. Do people do more than one fellowship? Usually not. It is possible, but you have to think all of this takes time, and fellowship is time consuming. So you've already done 4 or 3 years, but usually 4 years of medical school, 4 years or 3 years of emergency medicine residency. So you've already had 7 years of training. That's the minimum, right? Or I guess 6 if you went to 3-year medical school, but let's just say 7 years of training. So doing another fellowship, it's usually 2 or 1 year. So then you're getting at 8 years, right? At minimum. To do another fellowship, that may be another year or 2 years. So then you're just adding on time. And anytime you do fellowships and you get more training, you want to make sure that you are understanding why you're getting the additional training, what job that may lead to, what additional opportunities will be afforded to you, because you want to make sure that your goal of getting all this training and education is to actually practice medicine. Okay. So yes, it is possible to do more than one fellowship, but most people do not do that. There are some people who do more than one residency as well. They may have a change of heart and want to go from internal medicine to obstetrics and gynecology. Just depends on the person. Okay, so that's a good question about pediatric emergency medicine. So if you want to be a pediatric emergency medicine physician, so emergency medicine physicians are trained to treat pediatric patients. Okay, so I am able to treat pediatric patients as well. So within your residency, you get dedicated training with pediatric patients. However, there are a lot of specialized children's hospitals within the US that only want to hire pediatric trained emergency physicians, right? Because you can't think of kids as just little adults. They have different pathophysiology. They have different diseases. There's different ways that you do procedures on them. So it is a different skill set. Okay, so you can get to be a pediatric emergency physician 2 ways. So you either complete emergency medicine residency, well, I guess 3 ways. Complete emergency medicine residency and then work at an ER where you see adults and children. Okay, that's one way. The second way is complete an emergency medicine residency, and then you go on to complete a pediatric emergency medicine fellowship, okay? Or the other way is to complete a pediatric residency and then go on to complete a pediatric emergency medicine residency. Usually people tend to do that last method of doing a pediatric residency and then pediatric emergency medicine fellowship, but there are some people who do it the other way of doing an emergency medicine residency and then a pediatric emergency medicine fellowship. So once you get to that point, that's just something you want to reach out to physicians within that specialty to get their advice on what you may want to do. So yes, you can do fellowship several years after residency training. So you don't have to go straight from residency to fellowship. Depending on the fellowship, sometimes that can be more difficult or less difficult. It depends how well you increase your competitiveness by doing research and still having clinical experience within the setting for which you want to complete your fellowship in. So yes, there are some, I think when someone said schools, there are medical schools that are 3 years. It's kind of a new model, something that they're testing out at a few schools throughout the country. Specifically, I'm not sure which schools because I didn't go to a 3-year medical school, but there are a few schools that are 3 years. What they have done is figure out ways to cut some of your elective time and some of that time to shorten the length of time you're in medical school. So work-life balance. So as a resident in any specialty, work-life balance can be difficult to achieve just because you're working so many clinical shifts, and you're also in a time of heavy learning. So after shifts, you should be reading up on cases that you've seen and pathophysiology that you may not understand, and reading up on medications and different diseases. But you are able to achieve work-life balance. As you guys probably understand, pre-medical coursework isn't easy. Once you get into medical school is definitely not easy. Every step along the road to becoming a physician is not a walk in the park, so it does take dedication. But you want to make sure that you also incorporate wellness. So that is getting out and doing things that you enjoy, whether that be reading, hanging with friends, exercising, traveling, of course, pre-pandemic, but you want to make sure that you are still doing things that you enjoy and making sure that you are performing activities that help you de-stress. So yes, we take care of pregnant patients in the ER. So whether or not they go straight to the OBGYN at labor and delivery, it depends on how far along the patient is in their pregnancy. But oftentimes, even if they are far along, so they're at the stage with which the pregnancy is viable, meaning if they delivered the child right then, that with some medical attention, the child would be likely to live. There is, we still have to stabilize the patient. So if a patient is in a bad car accident and has acute fractures and bleeding within the lungs or different type of pathology going on, that would be something that we would see in the ER. Stabilize that patient, and then they would have further monitoring within the OB department. And also within the ER, you can always consult your specialist. So, you know, if you have a critical pregnant patient coming in that you're expecting, you can always call OB. Awesome. So someone said they're applying to osteopathic medical school, so I'm excited. Yay. Yeah, feel free to reach out to me if you have any questions. My email is here, drkjsmith1@gmail.com. And then I'm also on Instagram if you guys do that. So you can find me on Instagram as well. So I think that is the end of the questions. And I just want to thank, again, Web Shadowers. This is a wonderful program. You guys are doing a great job of keeping up with the program and attending these sessions. And I hope you continue to enjoy the rest of the sessions within the program.
Thank you so much, Dr. Smith, for presenting for our Web Shadowers. We loved how many visuals you provided in your presentation, and it was an honor to have you and learn from you. Thank you.
Thank you. Have a good night, everyone.
Everyone, make sure you check out her socials. Her Instagram is drdr.kjsmith. And then as for everyone else, the link for the Google form has now been posted in the chat box, and it will be in the description of the video shortly. Please fill it out within the next 30 minutes for us to receive verification of your attendance. Again, thank you so much, Dr. Smith.
Thank you.
Bye.